So, as take-home points, the renal system develops from three embryonic structures. That's the pronephros that degenerates in the 4th week, the mesonephros, and the metanephros, which is composed of ureteric blood and blastema. That one ultimately forms the adult kidney. Just also make sure to remember that this interaction between ureteric blood and metanephric blastema is called reciprocal induction, and that is critical for kidney development. Failure in this process can lead to renal agenesis. And since we're talking about renal agenesis, if it happens bilaterally, meaning on both sides, we're going to get oligohydramnios. And oligohydramnios can lead to Potter sequence. Just remember pulmonary hypoplasia, twisted face and limbs, renal failure, and also remember that it's often incompatible with life. Third, let's talk a little bit about horseshoe kidney. Horseshoe kidney results from the fusion of the inferior poles of the kidneys, which does, however, does not mean that those kidneys can't function. Sometimes, and oftentimes, they do function normally. However, they're often obstructed by the inferior mesenteric artery, which can result in hydronephrosis, can increase your risks for kidney stones, and can increase your risks for UTIs. This is seen especially in patients that carry the syndromes of Turner, Down, Patel, or Edwards. And finally, a duplex collecting system arises from two ureteric buds developing on each side. Now that leads to failed ureter development. Even though you have two, they're not as good. So you can have poor urinary flow with vesicoureteral reflux leading to UTIs, and you can see that radiological droopy lily sign.
Part 2.
And now for the renal anatomy take-home points. First, let's remember kidney position and landmarks. The right kidney is slightly lower than the left, and that is because of the liver, which is much, much larger, with the left kidney being therefore located under the 11th rib, and the right just below the 12th. Also, kidney hilums, they align with the L1 vertebra, and they terminate, and the kidneys themselves, they terminate near the L3 and L4 intervertebral disc. Second, if we think of organ relationships, the right kidney lies under the liver and near the duodenum, and also close by to the right colic flexure. The left kidney is close to the stomach, to the spleen, to the pancreas, to splenic vessels, and to the left colic flexure. Now, if instead of going through the anterior relations, we take a transversal cut, we're going to find Gerodes fascia. This protective sheath encloses the perirenal fat and also the adrenal glands. It's the same compartment that involves kidney and adrenals. This is very critical for surgical approaches to the kidney. For kidney regions, the cortex contains glomeruli and convoluted tubules. The medulla houses loops of Henle and collecting ducts, and the collecting system is composed of the minor and major calyces, pelvis, and ureters. If we think of the renal arterial system, we're going to remember that blood flows through the renal artery, which then branches out into segmental arteries, interlobar arteries, arcuate arteries, and then interlobular arteries, just before reaching the glomeruli in their afferent arterioles. For venous anatomy, on the other side, the left renal vein is much, much longer. It crosses anterior to the aorta and just beneath the superior mesenteric artery, which makes it prone to nutcracker syndrome and associated left-sided varicocele. And finally, for the ureter path, well, let's just remember under, over, and under. Ureters pass under the gonadal arteries, over the common iliac arteries, and under the uterine artery in females, or under the vas deferens in males.
Part 3.
Now, for our first take-home point, let's remember of the divisions of water percentage in our body. 60% of our whole body weight is water. 40% of that water is intracellular. And our second fluid division is that 20% of our entire body water is extracellular. Now, extracellular is 25% plasma and 75% interstitium. So, two major divisions, intracellular versus extracellular. Extracellular is further divided into volume that stays in the plasma and volume that stays in the interstitium. Those are the things that we call fluid compartments. The effective circulating volume, that's a functional concept, and it describes the blood volume that actively maintains tissue perfusion and oxygenation. It's influenciated by many things like cardiac output and vascular tone. Fluid shifts between compartments, they depend on the osmolarity of the fluid that is either gained or lost, and that influentiates both ECF or extracellular fluid and ICF or intracellular fluid compartments. It's going to change the volumes of each of those compartments. The first example we saw was concerning isotonic fluids. Now, if you gain or lose isotonic fluid, you're going to change the ECF volume, but you don't generate osmotic gradient, meaning there is no change on the other side. The intracellular portion stays the same. Meanwhile, if you have hypertonic or hypotonic fluids gained or lost, you're going to have shifts between intracellular compartments and extracellular compartments. Just remember that whatever of those fluids you're gaining or losing are changing initially just the ECF. Then the ICF, or the intracellular side, moves in direction to reach a new osmolarity equilibrium. At the end of the day, all they want is to have the same concentration. If you just remember that, you can think your way through what happens. So, as we said, if I add isotonic fluids, ECF increases, ICF remains the same. If I add hypotonic fluids, what happens is that ECF increases, but becomes hypotonic, right? So, guess what? ICF increases as well. There is edema. If, on the other hand, we add hypertonic fluids, what happens is the ECF increases and becomes hyperosmolar, meaning it's going to start to pull fluids. The ICF then decreases in volume. This is an effective way to treat things like cerebral edema. What is the definition of clearance? Well, one, it's the amount of plasma volume that can be cleared by unit of time. Clearance is basically volume over time. And we talked about some of the formulas, right? So clearance of any given substance is the urinary concentration of that substance versus the urinary outflow rate divided by the plasma concentration of that very same substance. 8. Glomerular filtration rate, or GFR, that's a key indicator of kidney function. It measures the kidney's ability to filter solids from the blood, and it can be calculated from the filtration fraction of the renal plasma flow. Filtration fraction equals GFR divided by renal plasma flow. What is the ideal substance that we should use if we want to calculate the GFR? Well, it's a substance that is filtered but not resorbed and not secreted. Now, everything that would enter the glomeruli would therefore be excreted. And the only way of clearing the plasma from that substance would be filtering through the glomeruli. We know that such a perfect substance doesn't exist, but it helps us understand what is the advantages and limitations of each one of the other ones that we're able to use. What can we conclude if the clearance of any given substance is lower than that patient's GFR? We know that that substance is being effectively resorbed. What about if the clearance of that given substance is greater than that patient's GFR? Then we know that that substance is being actively secreted. Why creatinine superestimates the GFR? Because it's also secreted. And also, remember, it depends on muscle mass. And finally, what are the forces that drive glomerular filtration? Well, those are the Starling forces. Remember, hydrostatic, oncotic pressures. The balances between those will drive fluid passage throughout the glomeruli. And how does our kidney kind of self-regulate that? Well, it has the myogenic mechanism, which constricts the afferent arteriole based on blood pressure that stretches the muscle in those vessels, and also by tubuloglomerular feedback, in which the sodium that reaches the macula densa is effectively sensed, and that way the system gets a sense of whatever volume we have and constricts the afferent arteriole appropriately. And how those mechanisms keep the GFR stable when the pressure drops? Well, decrease in sodium chloride is going to be directly proportional to hypovolemia. So if the pressure drops, we're going to have a corresponding drop in the amount of sodium chloride that reaches the macula densa. Macula densa then signals to the JG cells, which synthesize renin, and therefore increase the production of angiotensin II, which will constrict the efferent arteriole and raise the pressure inside the glomeruli. Also remember, it's renal, it's renin, angiotensin, aldosterone. So the end result of synthesizing more renin is that you also have aldosterone. So there's also widespread system-wide vasoconstriction, which raises the blood pressure even in the setting of hypovolemia. Very elegant mechanism, very important mechanism.
Part 3.
Welcome to our take-home points for our acid-base disturbances part 1 class. Well, let's get this started. So first take-home point is that a pH is kept at a normal level of 7.35 to 7.45. This is necessary so we can have normal enzymatic function across our body. Number 2 is remember the compensations. So whenever we have a process going on, we can either acidotic or alkalotic process going on, we can either compensate with our respiration or we can compensate through our kidneys. Whenever you're compensating with your respiration, you just need to change your respiratory frequency. So that happens really, really fast. However, to compensate through your kidneys, that takes days. So just as a brief note, whenever we alter our respiratory frequency, what we're really changing is the partial pressure of carbon dioxide, or PCO2. So respiratory compensation is going to occur because of that altered ventilation, which adjusts PCO2. Now, let's remember the Henderson-Hasselbalch equation. I don't want you guys to memorize all of this, but it is important for you guys to know that our pH is proportional to our concentration of bicarbonate and our partial pressure of CO2. Look at this. This is a fraction. If I increase the partial pressure of CO2, what happens to the pH? Decreases. So you get acidotic. If on the contrary, I change the HCO3 and let's say I decrease it, your pH also goes down. So less bicarbonate, more acidotic. Well, what if the bicarbonate goes up? pH goes up. More bicarbonate, less acidotic. Makes sense, right? Fourth, we have the very important concept of anion gap. Now, anion gap can be calculated by the difference between sodium, chloride, and bicarbonate. It really helps differentiate metabolic acidosis. Now, if we have a high anion gap, we know that we are accumulating a different source of anion, an anion different than chloride and different than bicarbonate. So what's happening is we're introducing acid into the system. So high anion gap metabolic acidosis indicates that an exogenous or a different acid has been introduced into the system. While normal anion gap metabolic acidosis simply suggests that we are losing bicarbonate. Remember, this is important because anion gap helps you determine the cause of that metabolic acidosis. So things like mud piles refer to the high anion gap causes, and things like hard ass refer to the normal anion gap causes. Winter's formula can be calculated as well, and it helps us predict the respiratory compensation in metabolic acidosis. It is 1.5 times bicarbonate plus or minus 2. So, with a variation of 2 points, if you multiply bicarbonate concentration to 1.5 and add 8 points, you can predict the PCO2 that would be expected for any given metabolic acidosis. Now, this is a formula that is important to commit to memory. The delta-delta is a little bit less high yield, but also interesting to memorize. So it is the variation of anion gap divided by the variation of bicarbonate. If it's less than 1, it suggests that we have a non-anion gap acidosis. If it's 1 or 2, we have pure high anion gap acidosis. And if it's more than 2, we have that high anion gap metabolic acidosis and as well a metabolic alkalosis. So whenever we have a high anion gap metabolic acidosis, we calculate the anion gap to check for concomitant metabolic processes. Winter's formula can really only be used to evaluate the presence of a concomitant respiratory process. There is a lot of important and classical clinical cases that is important to remember, and one of them is what happens whenever we have an aspirin overdose. Aspirin overdose is a classic mixed acidosis picture. It's mixed anion gap metabolic acidosis with respiratory alkalosis. And finally, we always need a systematic approach when tackling those questions of acid-base disorders. A good systematic approach is evaluating the pH, calculating the anion gap, applying Winter's formula, and then assessing the delta gap.
Part 5.
Welcome to the take-home point for part 2 of our lecture of acid-base disorders. So, for the first one, we're going to talk about respiratory acidosis. Now, respiratory acidosis is associated with the accumulation of CO2, which can happen both chronically or acute. Important acute examples that we brought up in the lecture were pneumonia, acute COPD exacerbation, or a CNS depression. Now, those are things that change your respiratory rate very abruptly. However, chronic cases include COPD and ALS. Those are conditions patients have been living with for quite some time, and they adjust their respiratory frequency based on that. For acute cases of respiratory acidosis, we know that bicarbonate needs to be increased 1 milliequivalent per liter for every 10 millimeters of mercury that is increased in the PCO2. So let's say we have a PCO2 of, 60. Now, the normal one would be 40. If you're having 60, you increased 10 two times. So 10 one time, 50, 10 one time, 60. So if you did it 2 times, then you really do need 2 milliequivalents of compensation in your bicarbonate. Now, if that were to be a chronic process, well, you would be able to compensate a little bit more, wouldn't you? We just talked about how renal compensation takes days to take place. So if you're compensating for a very long time, well, that's a 4 to 5 per every 10. Finally, we talked also about respiratory alkalosis. Now, respiratory alkalosis is going to be related to an increase in respiratory frequency. When we increase our respiratory frequency, we take out more CO2 from our body. Now, that leads to a huge CO2 loss, which could be clinically associated with things like anxiety, fever, and anemia. All of those things are common triggers that make our respiratory rate go up. Now, it could also be due to chronic causes. Some people actually have chronic microembolisms happening in their lungs, so chronic pulmonary embolism. Or also, some people just live with a thyroid that is upregulated on a baseline, hyperthyroidism. Both of those things would tend to increase your respiratory frequency also on a baseline. For the acute respiratory alkalosis, bicarbonate needs to be decreased by 2 milliequivalents for every 10 millimeters of mercury that we decrease in the PCO2. Very similar rationale to what we just spoke. But now, if it's chronic, then again, you can adjust a little bit more. So you would have an expected decrease to 4 to 5 milliequivalents per liter for every 10 millimeters of mercury that we decrease in the PCO2. And finally, we also talked about metabolic alkalosis. Now, metabolic alkalosis is characterized by this high pH and elevated bicarbonate. This is caused either because you're losing H+, like let's say you're vomiting, or because you're gaining bicarbonate. Let's say you're using a lot of antacids. Regardless of the cause, whenever we are assessing metabolic alkalosis, we always need to look at the urinary chloride. Now, low urinary chloride indicates saline responsiveness, so you can treat this person by giving them fluids. High urinary chloride, however, points you in a very different direction, and it can suggest some rare conditions like Bartter syndrome or mineralocorticoid excess, which are generally saline resistant. So giving fluids to those patients wouldn't do a thing to their acid-base disorder. And finally, one last remark that I really wanted to stress with you guys is practice based on questions. All right, acid-base disturbances can be tricky sometimes, but if you do a whole lot of questions, it becomes mechanical. So make sure you do a whole lot of questions before you take your exams.
Part 6.
Welcome to the take-home points for the nephritic syndrome lecture. Now, for the first take-home point, let's remember the glomerular structure. The glomerular structure consists of 3 primary components: the capillary endothelium, the basement membrane, and the podocytes. The nature of the damage to these structures determines the extent of glomerular dysfunction, which exists on a spectrum between nephrotic and nephritic syndromes. The hallmark feature of nephrotic syndrome is significant protein loss, primarily albumin, which exceeds 3.5 grams of protein lost per day. Additional features include hyperlipidemia and an increased risk for thrombosis due to the loss of antithrombin 3, which also predisposes those patients to having deep venous thrombosis and pulmonary embolism. Nephritic syndrome, on the other hand, is characterized by inflammation and bleeding. Key clinical findings here include oliguria, hypertension, and proteinuria, typically less than 3.5 grams per day. 5. Post-streptococcal glomerulonephritis typically develops 2 to 4 weeks following an infection with group A strep. This occurs either in the pharynx or the skin. This condition represents a type 3 hypersensitivity reaction. It's more common in kids, but in adults, it can progress to rapidly progressive glomerulonephritis, which has a poor prognosis and necessitates biopsy. In RPGN, light microscopy is going to reveal that crescent formation and immunofluorescence patterns play a critical diagnostic role. Those patterns can be linear, granular, or negative. Negative is also referred to as palsy-immune glomerulonephritis. A granular immunofluorescence pattern is associated with post-streptococcal glomerulonephritis, or diffuse proliferative glomerulonephritis, the latter of which is more common in patients with lupus. A linear immunofluorescence pattern is indicative of Goodpasture syndrome, which typically presents with hemoptysis and hematuria. If the IF pattern is negative or palsy-immune, you really need to pursue that ANCA testing for making the diagnosis. The ANCA is associated with microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis. C-ANCA is associated with granulomatosis with polyangiitis. IgA nephropathy or Berger disease is the most common form of glomerulonephritis. It's characterized by episodic hematuria following mucosal infections and IgA deposition in the mesangium. Lastly, Alport syndrome is an X-linked disorder, which is caused by a defect in type 4 collagen. It's associated with hematuria, sensory hearing loss, and ocular abnormalities.
Part 7.
So welcome to the take-home points of glomerular diseases. Now, this is our lecture about nephrotic syndromes. For our first take-home point, we have minimal change disease. Remember, it's the most common cause of nephrotic syndrome in kids. It typically is idiopathic, but it may be triggered by an immune response to infections or immunogens. It is associated with Hodgkin's lymphoma, and that's because of increased cytokine production. It has some normal findings on light microscopy, but effacement of food processes whenever you do electron microscopy. And it responds exceptionally well to corticosteroids. Now, FSGS is the most common cause of nephrotic syndrome in Hispanic and African American populations. It's usually idiopathic, but it can be linked to conditions such as HIV, heroin use, and sickle cell disease. It features effacement of food processes on electron microscopy, and it shows a very poor response to corticosteroids. For membranous nephropathy, it is the most common cause of nephrotic syndrome in Caucasian adults. It can be primary due to antibodies against phospholipase A2, or it can be secondary, which is linked to drugs and infections. Drugs, let's remember, NSAIDs, penicillamine. Infections, hepatitis B, hepatitis C, syphilis, solid tumors, and lupus. Membranous nephropathy has a very poor response to corticosteroids. Light microscopy will reveal thickening of the glomerular basement membrane. An electron microscopy will demonstrate the hallmark spike and dome appearance. Membranoproliferative glomerulonephritis, well, that one can present with both nephritic and nephrotic syndromes. Light microscopy has the classic tram track appearance, which is caused by mesangial cell proliferation, splitting up those immune complex deposits. MPGN is divided in two types. We have type 1, associated with subendothelial deposits, commonly linked to hepatitis B and hepatitis C infections. We have type 2, which involves dense deposits in the basement membrane. It is characterized by the presence of C3 nephritic factor, and it stabilizes C3 convertase, leading to excessive C3 consumption. Now, diabetic nephropathy results from non-enzymatic glycosylation of proteins. It leads to glomerulosclerosis and hyaline arteriolosclerosis, particularly in the efferent arteriole. There is a high glomerular filtration pressure, which contributes to protein leakage and nephrotic syndrome. Microscopically, it's characterized by Kimmelstone-Wilson nodules, which are eosinophilic nodular glomerulosclerosis, which is visible on light microscopy. And finally, amyloidosis is caused by amyloid deposition in the mesangium. Congo red stain reveals apple green B refringence under polarized light.
Part 8.
Welcome to the take-home points for the urinary tract infections lecture. So for our first take-home point, we have risk factors. What are the risk factors for UTIs? Well, when you think of risk factor for UTIs, Think of anything that facilitates bacterial ascension. Short urethra in the case of ladies, long time of urinary stasis, meaning retaining that urine, not going to the bathroom when you want to. All of those things facilitate bacterial ascension. Other examples, other than those we just discussed, short urethra, female sacs, catheters, anything that facilitates bacterial ascension. Sometimes when we're talking about urinary tract infections, we come across the term sterile pyuria, meaning presence of leukocytes but no identifiable bacteria. Which ones are the bacteria that usually lead to that finding? Those are Neisseria and Chlamydia. And talking a little bit about epidemiology, we discussed how young, sexually active females are the preferential epidemiological group for Staph saprophyticus. Staph saprophyticus UTIs are usually seen in young, sexually active females. When we talked about pyelonephritis, we talked about how pyelonephritis classically displays a striated enhancement in the CT scan. Pyelonephritis may also present with white blood cell casts. Chronic pyelonephritis may lead to thyroidization of the kidney. Regardless of the type, thiazide diuretics and a low sodium diet can help with calcium stones. Uric acid stones are radiolucent. Struvite stones are related to infections with Proteus. And those were our major take-home points for a urinary tract infection lecture.
Part 9.
Now it's time for the take-home points. So, number 1, urinary sodium and fraction of excretion of sodium are both indicators of tubular function. Remember, one of the main things about our kidneys is that we need to be able to retain sodium when we want to, and we need to be able to excrete sodium so we can regulate our water balance in our body. Therefore, sodium itself is a marker of tubular function. And when we look at the urine and see the urinary concentration of sodium, or the fraction of sodium that we're excreting, we have an indirect marker of tubular function. Number 2, BUN to creatinine ratio. If the BUN to creatinine ratio is greater than 20, we have larger BUN resorption. Remember, creatinine is a fixed portion of this equation. BUN is the thing that changes. And this leads us to number 3. If BUN to creatinine ratio is greater than 20, it means that the cause for a renal dysfunction is pre-renal in nature, meaning it's more to do with the volume that reaches the kidneys. If not a whole lot of volume reaches the kidneys, we're going to want to try and get as much BUN back as we can through resorption. Remember, resorbing a little bit more BUN, you also resorb water. So it's a way that our kidneys have to try and retain more volume. Number 4, in renal failure related platelet dysfunction, what happens is an inhibition of both adhesion and aggregation. This is the key hallmark of pathophysiology in renal platelet dysfunction. Number 5, ATN, or acute tubular necrosis, can happen to both ischemic and nephrotoxic causes, meaning you can either have low flow leading to ischemia and then necrosis, or you can introduce a toxin that will lead to necrosis directly. For number 6, ATN, or acute tubular necrosis, has a pathological characteristic of muddy brown granular cast. This is a pathological hallmark of ATN. AIN, or acute interstitial necrosis, presents with fear. And what does fear stand for? Fever, eosinophilia, azotemia, and rash. AIN precipitants can be remembered by the 5 P's. Now, which one are those 5 P's? Number 1 for P, for diuretics. Number 2, pain-free, NSAIDs. Number 3, penicillin. Number 4, proton pump inhibitors. And number 5, rifampin. As for number 9, Papillary necrosis precipitants can be remembered by another mnemonic, which is SAD Papa with papillary necrosis. Now that SAD with double A stands for sickle cell disease, acute pyelonephritis, analgesics, and diabetes type 2. And finally, for our last take-home point for today, number 10, renal osteodystrophy. Now, renal osteodystrophy arises because of diminished 1-alpha hydroxylase activity. That 1-alpha hydroxylase activity combined with decreased phosphate excretion both lead to renal osteodystrophy. Those are the inciting events for renal osteodystrophy.
Part 10.
Welcome to the take-home points for our class on renal neoplasias. So without further ado, first one, we talked about angiomyolipoma. Remember, everything's in the name. It has vessels, it has muscles, it has lipids. This is a benign hamartoma, but it's often associated with tuberous sclerosis. For number 2, we spoke of renal cell carcinoma. Now, this is the major highlight of this lecture. It usually arises in the kidney upper pole, and it's linked to the VHL gene, which is located on chromosome 3. Now, that gene will result in increased production of certain proliferation factors like VEGF and PDGF, which both will increase your angiogenesis. Well, how does renal cell carcinoma present? We talked about a classic triad of frank pain, hematuria, and palpable mass. Those symptoms can be delayed because kidneys are located in the retroperitoneum, so they have space to grow before you even see the first symptoms. Renal cell carcinoma is also associated with some very serious paraneoplastic syndromes. We have polycythemia because you can have increased DPO production. You have hypertension because your kidneys can upregulate your renin production. You also have hypercalcemia, and that's because you produce a peptide that is very similar to your PTH. That's a PTH-related peptide. And you can also have Cushing syndrome because of that increased ACTH. Now, staging-wise, which is essential for treatment and prognosis, we're going to look at 3 major things, right? We're going to look at size, we're going to look at renal vein invasion, and we're going to look at presence of distant metastasis. Remember, this is something that can present very late in its course. So oftentimes, we can find this tumor with the patient having been completely asymptomatic until the point where he started having distant metastasis. Number 6, we spoke of von Hippel-Lindau. Now, von Hippel-Lindau is an autosomal dominant condition which is associated with both renal cell carcinoma and those cerebellar and retinal hemangioblastomas. Very important buzzword here. Number 7, we spoke of Wilms tumor. Now we're looking at kids, right? We're looking at renal tumors in kids. Now, this is because of a mutation of the WT1 gene, which is on chromosome 11, and it presents in kids on ages 2 to 4 years old. Presentation here would be hypertension and hematuria. We have 3 major syndromes that are linked to Wilms tumor. We have the WAGR complex, which involves Wilms, aniridia, genital anomalies, and mental retardation. We have the Beckwith-Wiedemann, remember that Wiedemann syndrome? That's the one that has the hemihypertrophy. This is associated with WT2 mutations. And we also have the Dennis-Dersch syndrome, which has the diffuse mesangial sclerosis and also the Mayo pseudohermaphroditism. Just remember, renal cell carcinomas tend to invade that renal vein, and it can lead to complications such as left-sided varicocele. That's in the left side because of those anatomical correlations. Histologically, the renal cell carcinoma has a clear cell morphology, right? It's also called clear cell cancer for that reason. While Wilms tumor is going to have a mix of blastema, stromal, and epithelial components.
Part 11.
Welcome to the take-home points of our class on chronic renal failure and cystic diseases. So, for number 1, we're talking about chronic kidney disease, which often stems from diabetes, hypertension, or glomerular diseases. It results in irreversible damage across all kidney compartments. Number 2, what are the end-stage renal disease histological changes? Well, those are very uniform. We're going to have glomerular sclerosis, we're going to have a fibrotic cortex, we're going to have chronic inflammation, and we can even see that thyroidization of the tubules. Number 3, uremia really is a hallmark of chronic kidney disease, and it manifests as nausea, platelet dysfunction, pericarditis, encephalopathy, and urea crystal deposition, which can make your skin really itchy. Complications of CKD really include metabolic acidosis, dyslipidemia, hyperkalemia, sodium and water retention, anemia, and renal osteodystrophy. Now, this happened because of impaired essential renal functions, like erythropoietin synthesis or phosphate excretion. Management of CKD usually involves dialysis or renal transplant. But just remember, long-term dialysis also has some dire consequences, and it increases your risk of renal cysts and renal cell carcinoma. Now that we're talking about renal cysts, well, let's start with simple renal cysts. Those are benign, whereas complex renal cysts would pose a very higher malignancy risk. Cysts can be considered complex when they have those septations or solid components, meaning heterogeneity within the cyst. 7, we're talking about autosomal recessive polycystic kidney disease, or ARPKD. Remember, this presents at birth, and it's really bilaterally enlarged kidneys, which are associated with Potter sequence, pulmonary hypoplasia, and congenital hepatic fibrosis. This can be deadly even in utero, very severe condition. Autosomal dominant polycystic kidney disease, however, takes a little bit longer to develop. This is something that we see in adults. It's linked to mutations in APKD1 and APKD2, which will result eventually in hypertension, hepatic cysts, and Barry aneurysms. Just remember that family history of Barry aneurysms. Medullary cystic kidney diseases lead to very small kidneys with cysts that are localized in the medulla. Now, this is distinct from the enlargement that we saw in all of those polycystic diseases. And for our last take-home point, microalbuminuria is an early marker of diabetic kidney disease. It emphasizes the importance of early detection in diabetes management.
Part 12.
And now for our take-home points for the pharmacology lecture, part 1. So first, PCT and descending loop are both water permeable. Number 2, the blockage of carbon anhydrase-related acid-base disorder leads to non or normal anion gap metabolic acidosis. 3, type 2 tubular acidosis has a urinary pH that is initially greater than 5.5. 4, acetazolamide is a diuretic used initially for the treatment of glaucoma, pseudotumor cerebri, and mountain sickness and uric acid stones. Number 5, mannitol's major side effects are heart failure exacerbation and pulmonary edema. Number 6, the ascending limb is impermeable to water. And also, loop diuretics may lead to both hypomagnesemia and hypocalcemia. And as we're talking about loop diuretics may lead to contraction alkalosis, meaning alkalosis that is promoted by hypovolemia. Loop diuretics may also lead to hyperuricemia, meaning high levels of uric acid.
Part 13.
Welcome to the take-home points of renal pharmacology part 2. So, for our first take-home point today, thiazide-induced sodium chloride cotransporter blockage increases calcium resorption. Thiazide diuretics are also indicated for nephrogenic diabetes insipidus. Third, thiazide diuretics may lead to metabolic disturbances such as hyperglycemia and hyperlipidemia. 4, thiazides may lead to hypokalemia. 5, aldosterone makes it so that the sodium that is resorbed at the expense of potassium. 6, aldosterone makes urine acidic. 7, potassium-sparing diuretics increase life expectancy for patients with heart failure. Amiloride treats lithium-induced nephrogenic diabetes insipidus. Which diuretic has those anti-androgenic effects? That's a spironolactone. Spironolactone is our diuretic with anti-androgenic properties.
Part 14.
Welcome to the take-home points for Renal SIADH lecture. Well, for our first take-home point today, let's remember that SIADH leads to low serum osmolality. As for causes, SIADH can be caused by both CNS and pulmonary pathology. One key principle here is that PTH, the hormone, PTH trashes phosphate. Phosphate. PTH trashes the phosphate. Another important particle that we discussed this lecture is ANP, or atrionatriuretic peptide. Remember what it does? It augments the diuresis. What is a potential treatment for nephrogenic diabetes insipidus because of lithium? Well, if lithium is the cause, amiloride may help treat it. And since we're talking about diabetes insipidus, well, what are the urinary findings? Those are low specific gravity and low osmolality. Both of those in the urine. If urine osmolality does not rise with water deprivation, one of the potential causes for that is nephrogenic diabetes insipidus. One must make you remember the other. Now, nephrogenic diabetes insipidus, you don't rise urinary osmolality with water deprivation. What is a treatment for central diabetes insipidus? Desmopressin. What about treatments for nephrogenic diabetes insipidus? Hydrochlorothiazide and indomethacin. Let's also remember that correcting hyponatremia too rapidly may lead to central pontine myolysis. In this lecture, we also talked about a whole lot of electrolyte disturbances. Now let's remember some of those with potassium. Well, hyperkalemia will lead to tall, peaked T waves. If we have hypocalcemia or hypomagnesemia, one of the clinical signs we may observe is tetany. Decreased deep tendon reflexes occur with hypermagnesemia. Flattened T waves and U waves can be seen with hypokalemia. And those were our major take-home points for our SIADH and electrolyte disturbances lecture. I'll make sure to catch you guys in the next one.